Good morning. My name is Brandon Harrison. I'm a PhD student at Temple University. Today I will be talking about. Okay. Today I will be talking about the development of the mobile phone-based transcutaneous bilirometer. And what a transcutaneous bilirometer is, it's a screening device used to screen for neonatal jaundice in newborn babies. Neonatal jaundice is a condition that is common to most newborn babies that's due to their inability to fully break down red blood cells. This leaves a byproduct protein called bilirubin circulating in a newborn baby's system. If this builds up in excess, this could also cause this condition called hyperbilirubinemia. This causes the skin and eyes to look discolored and yellow. Bilirubin is also known to be neurotoxic to newborn babies, bringing forth this brain damage condition called kernicterus. And if this goes undiagnosed and untreated, this could even lead to death in the baby. What we have here is a mortality global map rates. And what we see is that the mortality rate in low and middle income settings is higher than they would be in high income settings. And to understand this, we need to take a look at how neonatal jaundice is managed. And one thing that we know off the top is that in-facility delivery rates are higher in high-income settings than they are in low, middle-income settings. What that simply means is that in the U.S. or other high-income settings, more babies are being delivered in the hospitals versus in low-income settings where they're being born in villages. With in-facility rates being in hospitals for high-income countries, they have access to monitoring methods such as the gold standard serum bilirubin testing, which they take blood from the baby and spin it down to get the bilirubin concentration, or they use the surrogate standard transcutaneous bilirometry, which takes an image of the newborn baby's skin and gives back a bilirubin number. Physicians usually use that in conjunction with the Butani nomogram, which indicates risk zones for the baby based upon their bilirubin concentrations, and then they give a effective special treatment plan based on those neonates. But there's an established disadvantage of using these monitoring methods in low and middle income settings. The gold standard serum bilirubin testing, it requires facilities, and it's an invasive process which increases the risk for infection. The surrogate transcutaneous bilirometer is actually a little bit more advantageous because it doesn't require facility and it's not invasive, but it can be very costly. So what we wanted to do, though, is take that transcutaneous bilirometer and explore it a little bit more and understand how it works. So what happens here is light shines into the newborn baby's skin. Some of that light interacts with the skin and comes back out as diffuse reflected light. This diffuse reflected light, what is important here is the bilirubin peak at 475, at which they quantify the amount of bilirubin. So our idea or our concept was to take the basic functionalities of transcutaneous bilirometer and apply it to a device that's globally available, and that's the cell phone. The cell phone has the flash and your light source, being your light source, and the camera being your detector. And we initially believed by putting filters onto the back of the cell phone that we could do the same thing as a transcutaneous bilirometer. So a few years ago, we presented our feasibility study, which was conducted at Vanderbilt University, where we measured the forehead and sternum of the baby with our device, and we correlated results with clinical TCB. What we got from that study is that there was a positive correlation with the clinical TCB versus our device, but there was an unacceptable amount of error that was associated with that device. So moving forward, we wanted to build upon the things that worked well and improve upon our design and improve upon some analysis methods and study design. So last year what we presented is the change in our optical device. One of the things we changed was we changed to a newer model phone that utilizes the availability of using raw images to preserve the information in our images that we were taking with our device. Another thing we did is we developed a Monte Carlo model which simulated the optical light traveling into the neonate's skin and coming back out. What we wanted to do here is find the optimal parameters for for quantifying the high amounts of bilirubin reflectance levels through our device. And what we found with our Monte Carlo model is that if we could decrease the offset with the between the flash and the camera, that we could increase the amount of bilirubin reflectance values collected with our device. And by also tilting the flash closer to the camera, we could also increase our bilirubin concentration. So we then applied those to building our device in SolidWorks and 3D printed it and applied it to the back of the cell phone. And last year we presented the characterizations of that. So moving forward, we want to move to translating our device to clinical studies. In order to translate our device to clinical studies, there are a few things that we still needed to talk about. Having an application to go with our design, referencing and standardization technique, and how we were going to analyze our images. And with those done, then we would go straight to our clinical validation study. So some of the important things when we built our application was to make sure our application was simple and was flexible to nurses using our device due to the babies possibly moving around. And we did just that. The nurses are not required to take images at certain locations if they are not advantageous at the moment where the baby's fidgeting. The next thing was we didn't confine our cell phone to be just uploaded through computers. Our data management system allows us to upload images to a cloud-based service, AWS, which is an Amazon web-based server. And through this, we can remotely access this server and analyze these images from MATLAB. This sets us up for possible translation to low and middle income studies, allowing us to remotely, or physicians to remotely access the information from a computer and sending feedback possibly to the cell phone. Another important aspect of our device is our referencing and standardization technique. With most medical imaging devices, there's typically a reference standard that's used with it due to the LEDs being variable in intensities. A benchmark reference for this is a spectrum puck, which is usually made from engineered polymer called PTFE, due to its ability to have uniform reflectance and high reflectivity. But this is quite expensive at approximately $300, and it's difficult to keep clean. So we wanted to look for alternative approaches to that by having a polymer that is similar to a spectrum puck. It doesn't necessarily have to be as high reflectivity, but we do need it to be uniform. The alternatives polymer, we want it to also be inexpensive and easy to clean, since we'll be using this in low and middle income settings. So what we did is we evaluated 4 polymers, and what we were looking for is for the polymer to be similar to PTFE and have a high reflectivity and uniform across the board. And the polymer we've selected was ultra-high molecular weight polyethylene because it was similar to PTFE. And it's also easy to clean with just soap and water or alcohol. An example use of our reflectance standards, we took images of our reflectance standard on the process of around 20 days. And how we would use this is that if we saw any type of unnormal spikes in our data, we can normalize our data to that reflectance based upon what we're seeing in the spikes. Our last method is we needed to find a way to analyze our images once they came out of our clinical study. So our process flow for this is you taking the AWS server and downloading our images from there, converting our images from raw to DNG files, which are appropriate for our MATLAB, and then doing a little bit of image processing so that we can look at our images. Once we have our images, we use our reference standard to identify any abnormalities in our data. Then what we do is we take that data and we find a region of interest to quantify the amount of %R from that image. Initially, what we did originally in our feasibility studies, we took an area that was slightly close to the flash, but offset a little bit because we wanted a high signal-to-noise ratio. But from our Monte Carlo model, what we learned is that this area possibly needed to be moved over somewhere around here to have the highest reflectivity of bilirubin that we could collect from this. So moving forward, what we wanted to know is how do we find that region of interest that is appropriate for giving us the highest correlation. So to do this, we conducted a study with skin phantoms. Phantoms are medical devices used to mimic optical properties of tissues, and in our case, we're using it for skin. The base of our phantoms was this. We use a silicone elastomer as the base and TiO2 as scatterers. We also use synthetic chromophores to simulate bilirubin and melanin. We collected data with our spectrometer and our mobile phone transcutaneous bilirubinometer. And so then we used a optimization algorithm to find the highest position in our image where we had the highest correlation between devices. And this is the correlation with our spectrometer and our mobile phone. And so now we felt confident that we had an application and standardization technique and image analysis method for analyzing our images that would be coming out of our initial clinical study. So again, we conducted our study at Vanderbilt University, and we measured the sternum area, and instead of correlating our device with clinical TCB, we have changed to using total serum bilirubin. We changed this process due to the fact that clinical TCB has its own associated errors with it. So we wanted to use the total serum bilirubin, which has less. So in our preliminary results, what we got is a R squared of 0.96 and a relative standard error of 0.157, and again, a positive correlation. So our results basically are comparable to clinical TCB in the sense that we lowered our relative standard error, which is good, and it kind of gives us a legs to stand on moving forward with our clinical study. Some of the challenges we faced were coordinating our serum bilirubin draws with our measurements. In our study, we wanted to make sure we correlated our results with total serum bilirubins within an hour, and at the site that we were using this at, it was quite complicated in the fact that coordinating with nurses who were taking the serum bilirubin draws at like 3 in the morning, and then our nurse who was using the phone measurements, and who also had to consent the evening before with the parents. So now, moving forward, we've worked those challenges out, and we have a process where we are getting consistent data now. Our target enrollment in the next 2 months is about 60 infants, and if the results still look like this, we'll be confident in moving forward to low and middle income settings. So ultimately, that's where we want to go with this. We want to move to low and middle income settings and do the same type of validation and have similar results. We have our partners at the AKTCTH Nigeria facility who are waiting for our cell phones, which we'll be sending out shortly. And there are some things that we still need to do, get approved by the ethics board, and validate a protocol, and make sure our resources are secured so we can move forward to low and middle income settings. At this moment, I'd just like to take a time to thank our founding sources, the Bill and Melinda Gates Foundation, Bond Scholarship, and our friends from Temple University and Vanderbilt University. And thank you.